Hi guys, good afternoon. Am I visible and audible to you all? Give me a confirmation in the live chat. Um, and if I am, we'll begin with the part 4 of this crash course that we had designed before INI-CET. Today is the last part, what I've done is I've posted a combined PDF of all the 4 parts on the Telegram group. So you can catch that and then you can have your own set of notes and you can see all those 4 links together also. So you can find those links together and the PDF on the group, on the Telegram group, alright? So let's begin then. Lots to do today. We have PNS X-rays, anomaly scan, cystic renal diseases. If time permits, I also discuss PNS anatomy. This I'll definitely discuss. If time permits, I'll also discuss head trauma and PET scan, which was left off from yesterday. Alright, so that is what it is. And following this, I hope you've not forgotten, 9 o'clock there's going to be a test, the link of which is going to be in the description, and I'll also post it at around 8:45, 8:30ish for you guys on the Telegram group, so you can attempt it in 15 odd minutes, won't take too much of your time, and you can get money also in the process, right, which is great. So these are the Amazon vouchers which Unacademy has been very kind enough to provide. Okay, apart from this, just one class today. I did not keep the BTR class because I felt it would have been just a repetition and you have better things to do, so just see the BTR previous series that we've had. It covers the most important things, right? Thank you, Ayush. And just be calm, all right? So now nothing much changes. Just have trust on yourself, in your mind and brain, that whatever you've studied, you just have to apply. It's gonna be like 200 patients who are coming to you and you have to get the diagnosis right. You have to get whatever is being asked to you right, all right? So take it with a calm mind, rule out options, answer is right in front of you, all right? So all of these things and more I will say again tomorrow to calm you guys down at 4 o'clock about how to attempt the paper. Just a short 30-minute class. I meet you one last time before the exam, and we'll discuss how to make the best of whatever we've put in, right? Okay, apart from that, 7 o'clock I will meet you today for radiology revision. Okay, so that is what we're gonna do. Just again half an hour session. Final most important images which I feel could turn up in an AIIMS paper, I will show you. Okay, ठीक है. Maastricht classification we have done in BTR scores, Himanshu. In the BTR scores जब हमने करे थे 2 episodes of scores, I have covered that there. Okay, plus subscription, iconic subscription you can avail, and these are the batch courses which are all ongoing. Okay, thank you. Thank you so much. And these are the various offers on the subscription. All right, so let's begin very quickly. 2 things. PNS X-ray views are asked very frequently in all exams, in fact, not just AIIMS. And anatomy, CT anatomy, INI-CET special. Okay, they love to ask you this. Okay, so let's begin. Just identify all of these. Yeah, you can revise, and it's just 9 classes which are there of hardly 30 to 40 minutes. So definitely make it a point to do it, alright? It'll be high yield for you, right? Okay. Tell me guys, what is this view? What is this view called when a person comes to you like this? This is a water's view. This is basically a plain water's view, or have we modified it? This has correctly been called as a modified water's view, because to a traditional water's view, what we've done is we've opened the mouth of the patient. Do you see this, that the mouth of the patient is open? So this is also referred to as open mouth water's view. One person also gave a name to it. Open mouth waters or modified waters is also called as a Pier's view. Same kind of view, but the mouth is closed, becomes a traditional waters view. Alright, so if they ask you what is this view, the correct answer, the precise answer would be that it's a Pier's view, right? What is it best for? It is best for these sinuses that you see right here, which are maxillary sinus. In fact, on the right side, can you see how there is this horizontal air fluid level, which indicates that there is sinusitis, right? So remember, best for maxillary sinus. Apart from that, I can also see frontal sinus. I can also see anterior ethmoidal air cells here. In the Pier's view, when mouth is open, additionally, what is this sinus? We can also see the sphenoid sinus, right? So it does not show us the posterior ethmoid. Everything else it does show us, best for maxillary What about this? This is the one which has been asked the maximum number of times. So if you don't know in the exam, mark this, which is Caldwell. Alright, तो अगर एग्जाम में नहीं पता कि क्या है, Caldwell मार देना. Ideally, you should know how to identify. These are pterygoid plates. Here, the pterygoid plates are gonna be overlying the maxillary sinus. Do you see how maxillary sinus ka triangle is not seen here? This is the best for which sinus? For these sinuses which are seen in plane, and these are seen as their most correct sizes. So this is the Caldwell view, which is the best for frontal sinus. All right, so you only see frontal sinus and anterior ethmoid here. No other sinuses visualized in Caldwell's view. Okay, what is this view right here? It's from the side. This is a lateral view, isn't it? This is a lateral view. What is the advantage of lateral view? It's the only view which will show us all the sinuses. Maxillary sinus, frontal sinus here, and all the ethmoid sinus as well as sphenoid can be seen here. But the disadvantage being overlap, right and left will overlap here, right? So none of these are actually done in practice. If you ask me practice में क्या करते हैं, only modified waters. This is the only one which is useful in practice, but for exams for some reason they love to ask. Okay, so remember waters view ऐसे लेते हैं. All right, so the mouth or the chin is in contact with the film. That is why this is also called as occipitomental view, because through the occiput to mentum is how the ray passes. All right, so this is occipitomentum, and do you see how mouth is open? On the other hand, if frontal is in contact, right, frontal sinus is in contact, it is called occipitofrontal view. All right, so occipitomental, other name of Waters view. Occipitofrontal, other name of Caldwell view. Fine. Do you want to, will you remember this? Yes. Okay, so these are the two views. Three more views that you need to know. No, Akhil. Reese view is something entirely different which is used for optic canal. Alright, it's not the same as lateral view. Just remember, Reese again is not done in practice, but for exam, named views are important. You need to know it's useful for optic canal evaluation. Okay, bas utna sa. It looks different from this. Okay, what is this? Wherein the child also has a cochlear implant. So when you see a cochlear implant, very nice. Think of a child who's called Stenver. Okay, Stenver नाम का एक बच्चा है who has cochlear implant. So Stenver's view is very useful for evaluation of cochlear implant. What about this? Kind of like lateral view, but a slightly oblique view. So this is a lateral oblique view wherein you see this. This is the sinodural angle near the mastoid air cells. So these are the mastoid cells. So this is very useful for mastoiditis, to see if the cells are pneumatized or they are sclerosed. Alright, so this angle here is called sinodural angle, or it is also called what? It is also called as Sitterly's angle, right? So this view right here is the Law's view. ठीक है, इसको Law's view भी बोलते हैं, and as all of you are correctly saying, also called as Schuller's view. ठीक है, so दोनों नाम are acceptable. What about this? Wherein we see foramen magnum at the center. So foramen magnum, remember जब भी ये दिखता है, it is very big like a town. So this is the town's view. Again, not very useful, not done really. Alright, so these are the various PNS views that you need to remember. ठीक है, ये याद रखना, इनमें से एक ना एक आएगा. Going on to the air cells. Alright, so going on to the ethmoid air cells on CT, which is very frequently tested. CT anatomy. First of all, tell me, anytime you want to evaluate the paranasal sinuses, what is going to be the best investigation? Investigation of choice क्या है? It is HRCT, isn't it? It's high resolution CT of the paranasal sinuses that we'll do, and that I'll show you to identify all of these cells. इससे पहले फटाफट theory कर लेते हैं. Agar nasi. What is the one-liner? A for agar, A for anterior. This is the anterior most ethmoid air cell. ठीक है, तो सबसे आगे आएगा agar nasi. Bulla ethmoidalis. What are the two things we need to know about bulla ethmoidalis? सबसे पहले it is the largest. It's the largest ethmoid air cell. Secondly, ये क्या form करता है? Is it a part of some unit? Yeah, it is a part of osteomeatal unit, है ना? तो जहाँ पे maxillary sinus खुलने वाला है, that unit का part I will see bulla ethmoidalis. So do you agree? I will see it in the same plane when the maxillary sinus osteum is opening, right? Keep that in mind. Onodi cell. It is the posterior most ethmoid air cell, and onodi ON. What does it do? Being posterior, it will go and impinge. If it is enlarged, it will go and impinge upon optic nerve, right? So it can compress on the optic nerve if enlarged. That is the importance. Haler ka ek hi line, where is it located? Infraorbital, right? So this is gonna be infraorbital air cell. A lot of times I've seen you guys mix up halar and agar nasi. Today you'll learn how not to mix them up. Conca bullosa क्या होता है? Just an anatomical variant wherein middle turbinate is pneumatized. Normally middle turbinate is a bone, but when it also has air, when it's pneumatized, correct, it becomes conca bullosa. Cool. So these are the one liners. अभी इन्हीं सबको CT में identify करना है. 5 minutes will be done. Okay. So see this. First of all, now tell me, जब ये plane देखा, when you are seeing this plane wherein this is maxillary sinus and it's opening, what cell are we expecting in its vicinity? I am expecting bulla ethmoidalis, right? So जब भी osteomeatal unit type का plane दिखे कि ये खुल रहा है into the nasal meatus, means that I'm dealing with somewhere around bulla ethmoidalis. So that is going to be a step 1. It's a coronal plane. Always they'll mostly give you coronal plane here. Alright. So this cell marked by the orange arrow, that is what is bulla ethmoidalis. Everybody getting this? What must be this bone which is connected to the inferior turbinate? It is actually a bony extension of the inferior turbinate forming again the osteomeatal unit. What must be this bone? This is uncinate, right? So this is the uncinate process, right? And ये क्या है? ग्रीन एरो से जो मार्क किया जिसमें एयर आ गया है. एयर ट्रेडिशनली डजंट बिलोंग हियर. सो ये क्या है? बेसिकली इंफीरियर टर्बिनेट हो गया. मिडल टर्बिनेट है जिसमें एयर है. न्यूमेटाइज मिडल टर्बिनेट. व्हाट इज इट कॉल्ड? कॉन्का बुलोसा, राइट? वेरी गुड. तो ये दो हमने आइडेंटिफाई कर लिए. ऑस्टियोमिएटल यूनिट सबको समझ रहा है? डू यू सी दिस ब्लैक कलर का पाथ विच इज गोइंग ऑन? सो मैक्सिलरी साइनस ऑस्टियम विच ओपन्स इनटू दिस पाथ. What is this path called? This rasta here, black color ka rasta which I have made red, is infundibulum. And when it opens into a 3D unit, that 3D unit is called what? That is called as hiatus semilunaris, right? So are all the components of osteomeatal unit also sorted for us? Maxillary sinus ostium, uncinate process, bulla ethmoidalis, infundibulum, hiatus semilunaris. Yeah? Everybody, so this is a very intricate area we need to know. अच्छा, साथ साथ ये भी बता दो, ये क्या है? बोनी प्रोसेस here, ऊपर anterior, this is क्रिस्टा गैलाई, right? So this is क्रिस्टा गैलाई here, और उसी के साथ में जो पतलू पतलू प्लेट्स है, इस प्लेट को क्या बोलते हैं? क्रिब्रिफॉर्म प्लेट. Alright, everybody remembers this. Anterior skull base, क्रिस्टा गैलाई, क्रिब्रिफॉर्म प्लेट. उसी के ऊपर जाएंगे लैमेले. दीज आर लेटरल लैमेले दैट यू नीड टू नो. और उसी के ऊपर आता है फोविया इथमोइडालिस. Did I just say too many words which are scary or it's familiar? It's seeming fine. So क्रिस्टा गैलाई, क्रिब्रिफॉर्म प्लेट, ऊपर जाते हुए फोविया इथमोइडालिस, बीच में लेटरल लैमेले. ओके. और मीडियल वॉल ऑफ ऑर्बिट को क्या बोलते हैं? जो वीकेस्ट है, विल ब्रेक वेरी वेरी क्विकली. दैट इज कॉल्ड लमाइना पैपिरेशिया, है ना? पेपर जैसा, थिन, इजी. ठीक है. तो ये सारे बिग बिग नेम्स यू हैव टू रिमेंबर. ऑलराइट, गोइंग अहेड. सो नाउ एंटीरियर मोस्ट इथमॉइड एयर सेल. तो कैसे पता चलेगा एंटीरियर है ऑन कोरोनल गाइस? कोरोनल देख के कैसे बोलोगे कि एंटीरियर है? ऐसे लिखा तो आएगा नहीं नीचे कि एंटीरियर है, एंटीरियर है. या सो द डिस्टेंस, द क्लासिफिकेशन, बेसिकली वी सी द डेप्थ ऑफ क्रिब्रिफॉर्म प्लेट. क्रिब्रिफॉर्म प्लेट कितनी नीचे है. Alright, so that is called Kiros classification. Again, something that AIIMS can definitely test for you. Kiros classification. So 1, 2, 3, depending on how deep it is. So जितना deep होगा उतना higher risk of injury, higher risk of CSF rhinorrhea during FES. FES क्या है? Functional endoscopic sinus surgery. Alright, so during FES, if it is a Kiros 3, there is higher risk of skull base injury leading to CSF rhinorrhea. Investigation of choice for CSF rhinorrhea. लास्ट डे है, सब कुछ जितना आता है बता दो. सीटी सिस्टर्नोग्राफी. ठीक है. अगेन HRCT करेंगे, साथ में सिस्टर्नोग्राफी करेंगे. सो रिमेंबर सीटी सिस्टर्नोग्राफी. अगर पूछा कंफर्म कैसे करोगे कि CSF है, इट इज इंडीड CSF rhinorrhea, you will say I will measure beta 2 transferrin, right? So that is how you know. चलो, coming back here, how do I know it's anterior? ये आंखें देखना हमेशा. ठीक है. Do you see these globes, right? तो जो हमारे ग्लोब्स हैं दे विल बी वेरी वेरी interior, right? So globes को देख के you will know, plus maxillary sinus will be very छोटू here. Do you see how two small maxillary sinuses are seen? So when you see a cell at this level, ये वाले just आए हैं baby cells. So these baby cells here, anterior most cells are the agonesi. Okay, so will you be able to now identify? Huh? Yeah, beta 2 microglobulin multiple myeloma. सो अगेन समबडी सेइंग हेलर, यही मुझे बताना था कि एंटीरियर, ए फॉर एंटीरियर, ए फॉर एगरनेजाई. अब इसी का मिमिक देखो जो आप हेलर बोल रहे थे. अगेन where do you see them? So again you can see the globes, but maxillary sinuses are now not very baby, right? Do you see how maxillary sinuses are larger? That means that we've gone behind, right? We've gone behind, and now you are seeing one cell just below the orbit. So this is gonna be halar. Yeah, is this difference clear? So the size of maxillary sinus is gonna be very helpful to you. हाँ, ठीक है, समझ गए सब लोग? हेलर एंड एगरनेजाई. और सबसे इजी जहाँ पे भी स्फिनॉइड साइनस दिखे, व्हेन यू स्टार्ट सीइंग द स्फिनॉइड साइनस एंड देन देयर इज वन एडिशनल एयर सेल, देयर इज वन एडिशनल एयर सेल posterior most, this is anterior, this is posterior, and in relation you have optic nerve, this is where you have optic nerve living. So if this grows, this can impinge on the optic nerve, ON for onodi cell. Okay, or they can give you posterior ethmoid cell also, like in AIIMS exam last time they gave you anterior ethmoid. So वो तो बहुत ही baby question, you just have to see am I anterior, am I posterior. So अगर मैं ऐसे पूछूं तो you will say it is anterior, अगर मैं ऐसे पूछूं you will say I am posterior. Okay, everybody, is this clear? PNS anatomy is done, 2 topics done. Going on to the third topic. Okay, PET scan, just very quickly, two questions have come in the past, we'll do them both. तो ये देखो MCQ, all are true about the image shown here except, what is this image? Has to be PET. Produces 3D functional imaging data, no radiation exposure, malignant cells show high uptake due to increased metabolism, used to detect tumor recurrence in brain tumors post radiotherapy. So which of these is true, I mean false about PET CT? First of all, how to identify PET CT? Background में bones will be white, CT, and then you see orange stuff. Orange stuff is where you have PET uptake. तो इसको बोलते हैं PET avid or showing PET uptake, right? Very good. Universally, everybody giving me correct answer. Wonderful. It does have radiation exposure because alone also, if I don't do CT, if I just do PET also, does it have radiation? Yes, it is dealing with gamma rays, the rays which have the highest energy, right? So it definitely has a lot of radiation exposure, and when I do a hybrid imaging like PET CT, it's double the radiation, isn't it? So this is definitely wrong. It gives us 3D functional data, it tells us about the function, the metabolism of the cells, and it is used to detect tumor recurrence, useful for malignancy staging. Yeah, तो कैसे करते हैं अपन? फटाफट 18 FDG is what is most routinely used. So 18 फ्लोराइड, इसका रोल क्या है? इसका रोल है कि ये पॉजिट्रॉन एमिटर है, और इट इज गोना एमिट समथिंग कॉल्ड एज पॉजिट्रॉन. डीऑक्सीग्लूकोज, ग्लूकोज का काम है टू एक्ट लाइक ग्लूकोज एंड गो टू सेल्स विच हैव अ लॉट ऑफ मेटाबॉलिज्म. डू मेटाबॉलिकली एक्टिव सेल्स नीड ग्लूकोज? Yes, we know that. When you are also very active, you need glucose, right? So wherever a lot of replication is going on, malignant cells need a lot of glucose because they rely on what effect? They rely on Warburg effect. They rely on anaerobic glycolysis, right? So they are gonna be very hungry for all the glucose that you send in. उसको फर्क नहीं पड़ता कि वो डीऑक्सी ग्लूकोज बाउंड टू 18F है या नहीं, या कोई भी साधारण ग्लूकोज है, इट वांट्स ग्लूकोज. सो आर 18FDG इज गोना गो इनटू द मैलिग्नेंट सेल्स जस्ट लाइक एनी अदर ग्लूकोज. बाकी ग्लूकोज का तो ग्लाइकोलाइसिस हो जाएगा, बट इसका क्या होगा? इट्स गोना बी ट्रैप्ड. Hexokinase will act and phosphorylate it and then it will be trapped. So now what will happen? Do you agree कि हर malignant cell में अपना 18 fluoride पहुंच गया है? That is what I wanted. 18 fluoride now starts acting and emits positron. Do we have electrons everywhere? भरे पड़े हैं. So we also have electrons. Now positron and electron, when they combine, that reaction is called annihilation. Alright, so annihilation होगा और ये दोनों जब मिलेंगे, there's gonna be release of two gamma rays, two very high energy gamma rays in opposite direction, and hence radiation being generated, right? So two gamma rays will be emitted and they will be meeting at the same time in our PET scanner. This is our PET scanner that I am using with gamma ray detector, isn't it? So this complete principle is called as annihilation कोइंसिडेंस सर्किट. कोइंसिडेंस मतलब दोनों एक साथ आने चाहिए, राइट, बिकॉज दे आर एमिटेड इन 180 डिग्री डायरेक्शन ईच. सो दैट इज द कॉन्सेप्ट. अगर पूछा कॉन्सेप्ट ऑफ पेट क्या है, यू विल से दिस. ओके, राइट एवरीबडी, इज दिस क्लियर? सो दिस इज द कॉन्सेप्ट ऑफ पेट. अब ये था रिपीट एम्स क्वेश्चन. एफडीजी पेट नेगेटिव ट्यूमर. आई नो मैलिग्नेंसीज हैव टू शो अपटेक, पर इनमें से किस में एफडीजी पेट डजंट शो अपटेक? टेल मी. Very logical also, right? So again, what do you think? Well differentiated tumors will show uptake, or undifferentiated or ill differentiated tumors will show uptake? Undifferentiated, right? So higher the malignant rate, higher the undifferentiation, higher is going to be the PET uptake. So इनमें से सबसे well differentiated कौन है? Yes, most of you giving me the correct answer. Typical carcinoid, right? It is very well differentiated. It's going to have somatostatin receptors. उसके पास malignant cells उतने सारा नहीं है, गंदे cells उतने सारा नहीं है, undifferentiated, right? So this is going to be FDG PET negative. Atypical carcinoid, undifferentiated, starting to be undifferentiated. Small cell, large cell carcinomas are again carcinomas, higher degree of undifferentiation. Okay guys, is this clear? So remember FDG PET negative tumors के लिए ना दो ट्यूमर्स बहुत इंपॉर्टेंट है. वन यू हैव टू रिमेंबर टिपिकल कार्सिनोइड. द अदर वन दैट आई वांट यू टू रिमेंबर इज म्यूसिनस कार्सिनोमा. Anytime I have mucinous adenosine, whether it is in the lung, whether it's in the appendix, whether it's in the ovary, whether it's in the pancreas, everywhere it's going to be typically FDG PET negative. Alright, so these are two tumors which are notorious to be PET negative. False positive कौन दे सकता है? Even though it is not a malignancy, but FDG PET is coming out positive. अपना भारत देश TB. So remember, whenever you have active TB infection, that is again something which will produce false positive PET uptake. Alright, it will mimic a malignancy. Okay. Yes. Apart from that, bronchoalveolar carcinoma also again mucinous की range में. Alright. So bronchoalveolar carcinoma also. There is no reason why. It's just the property. Okay. Yeah. So this is FDG PET के salient features you need to have in mind. थोड़ा सा extra edge क्योंकि INI-CET देने वाले हैं हम लोग. All of the following can be used as positron emitters except. माना most common 18 fluoride है, but और कौन से use कर सकते हैं? तो remember ये सारे ही. FNOC, FONC is what we can remember. अच्छा FONC, what was FONC score guys? Do you remember FONC score? That was used for what? This might come. It will be a lot of fun if this score gets asked. In the meanwhile, iodine 131. Remember, iodine 131 is not a positron emitter. It emits beta plus gamma rays. It is used for radioiodine therapy for thyroid CA. Yeah, FONC score is not for thymoma. No, not for neuroblastoma. It is for liver metastasis. Yes, very good. It is for liver metastasis following कोलोरेक्टल सीए है ना. तो लिवर मेट्स का प्रोग्नोसिस के लिए अपन यूज करते हैं इसको. ठीक है. तो अब आपने बोला थाइमोमा, तो थाइमोमा का स्कोर बताओ. अमेजिंग नेम, मासाओका कोगा स्टेजिंग. ऑलराइट, सो रिमेंबर मासाओका कोगा स्टेजिंग इज यूज्ड फॉर थाइमोमा. और एक भी गलत आंसर था नहीं. ठीक है. ऑलराइट, ओके, गोइंग बैक. आयोडीन 131 सबने सुन लिया. बीटा प्लस गामा एमिटर, रेडियो आयोडीन ट्रीटमेंट. ठीक है. ओके, कूल. एक और थोड़ा सा एक्स्ट्रा एच फॉर INI-CET, आइडेंटिफाई द इनकरेक्ट पेयर. ये सारे फैंसी पेट है विच वी हैव नाउ इंट्रोड्यूस्ड. सोडियम फ्लोराइड पेट, बोन मेटास्टासिस. दिस इज डेफिनेटली करेक्ट. इट्स द बेस्ट इन्वेस्टिगेशन वी हैव करंटली फॉर बोन मेट्स. रिमेंबर, अगर कोई पूछे मोस्ट सेंसिटिव कौन है बोन मेट्स के लिए इन टूडेज डे एंड एज, इज सोडियम फ्लोराइड पेट. इट इज नॉट बोन स्कैन. ओके, तो बोन मेट्स का सेंसिटिविटी का लिस्ट एक बार बता देती हूँ क्योंकि मुझे लग रहा है ये सवाल आ सकता है. सोडियम फ्लोराइड पेट, if this is not in the option, then go for 18 FDG PET. If this is not in the option, go for MRI, and then comes bone scan. All right, so bone scan is way down the line. Okay, as far as bone mets go. Choline PET for endometrial CA. No. Choline PET किसके लिए यूज करते हैं? प्रोस्टेट. So PMSA और कोलिन पेट, दोनों ही प्रोस्टेट सीए के लिए बहुत इंपॉर्टेंट है, आज की डेट में बहुत यूज होता है, पीएमएस लॉट्स ऑफ रिसर्च गोइंग ऑन इन एम्स अबाउट दिस, it might come. Okay, Dotanok pet neuroendocrine tumor, again एम्स का पेट क्वेश्चन अगर ये मतलब कोई पूछेगा, it is AIIMS. Okay, Dotanok pet, I will tell you more about it. C11 methionine pet, not very important, brain tumors. ठीक है, तो Dotanok PMSA pet जरूर याद रखना. Okay, prostate membrane surface antigen. डोटानॉक इज अगेन वेरी वेरी इंपॉर्टेंट, प्रीवियसली अपन यूज करते थे सोमैटोस्टैटिन सिंटिग्राफी, नाउ बेटर इज गैलियम 68 डोटानॉक पेट. व्हाट यू नीड टू नो हियर, इट टारगेट्स द सोमैटोस्टैटिन रिसेप्टर्स. दिस इज गोना बी वेरी यूजफुल फॉर न्यूरोएंडोक्राइन ट्यूमर्स ऑफ पैनक्रियाज, एक्सेप्ट कौन सा न्यूरोएंडोक्राइन ट्यूमर है विच डज नॉट शो अपटेक विथ डोटानॉक, वेरी इंपॉर्टेंट, insulinoma. Okay, apart from that, yes, paraganglioma slash pheochromocytoma also have a role. All pheochromocytoma controversies, we have done one midnight express. All right, I hope you guys just spend like 5-10 minutes revising that and you'll be sorted. ठीक है everyone, so this is about Dotanok pet. Remember, neuroendocrine, it's the best for gastrinoma. Gastrinoma shows us the highest uptake with Dotanok. ठीक है, चलो फटाफट अनोमलीज के अल्ट्रासाउंड देखेंगे, लास्ट टाइम भी एक सवाल आया था, सो फटाफट देखते हैं. सबसे इजी ये बताओ क्या है, व्हेन द क्रेनियम इज एब्सेंट एंड ऑन अ frontal plane you see eyes become very prominent because the skull is not there, just a dystrophic brain. What is this? The earliest anomaly to be detected, anencephaly, right? So this is anencephaly. It starts off with acrania. सबसे पहले क्या होगा कि स्कल बोन नहीं है तो ब्रेन बिकम्स एक्सपोज्ड, उसको क्या बोलते हैं, एक्जेंकेफली. स्लोली दिस ब्रेन इज गोना बी रिजॉल्व्ड एंड इट रिजल्ट्स इन एब्सेंट ब्रेन. सो दिस इज अ सीक्वेंस which ensues. Alright, so all of these mean basically the same disorder. Yeah, so this is frog eye. Yes, it can be detected in the first trimester scan at 11 to 13 weeks itself. Okay, cool. Going ahead to this, when you see the skull, फर्स्ट ऑफ ऑल ये देख के भी मैंने देखा है बच्चों को सेइंग एनेंकेफेली, बिकॉज दैट इज ऑल वी नो कि एनेंकेफेली आएगा. नो, दिस इज द स्कल, राइट? सो व्हेन यू सी द ब्रेन यू कांट से एनेंकेफेली. सो हियर द ब्रेन, द फ्रंटल डिप्रेशन इज देयर इन द cranium and this is cerebellum which is showing banana. So these are your famous signs, lemon and banana sign, which are associated with what? Which are associated with spina bifida. मत बोलना, say chiari. Alright, so say chiari malformation 2 more than 1. Alright, so see spina bifida, I knew it. Spina bifida is a very very non-specific term which just represents that the neural arch is not closed. Alright, so spina bifida तब मिलता है जब spinous process आपको नहीं दिख रहा है एक्सरे में, that is spina bifida. It's the mildest form. Alright, so don't say spina bifida, it is chiari malformation which shows us lemon and बनाना साइन. ओके, बट अगर एग्जामिनर ने और कोई ऑप्शन नहीं दिया स्पाइना बाइफिडा, वो भी हमारे जैसा है, मार्क स्पाइना बाइफिडा. ओके, नेक्स्ट, व्हाट इज दिस? व्हेन यू आर, तो दिस इज डिफरेंट, दिस इज डिफरेंट. फर्स्ट इमेज, व्हेन देयर इज ब्लैक माने फ्लूइड in the posterior fossa, means posterior fossa cyst. What will you say? Posterior fossa enlarged with a cyst, with vermis which is not there, cerebellar vermis which is agenetic, very very important. Dandy Walker malformation. Alright, so remember both Dandy Walker, Arnold Chiari can be detected antenatally. Alright, okay, what about this? So these are slightly extra है ना, तो ये मतलब मुश्किल है कि पूछेंगे, बट अगर पूछ लिया तो you will get very good brownie points. Alright, here what do you have? When there is a single thalamus, monoventricle, एक single ventricle है, means both the lobes have fused. When both the cerebral lobes fuse on the right and left side, what is that called? Good. This is called holoprosencephaly, and that is associated with what? That's associated with trisomy 13, which is Patau syndrome. Okay? Yeah, these are indications of MTP provided they get detected early in the anomaly scan at 18 to 22 weeks, and then usually it is put to the parents and you know, whatever they want basically. Alright, so these are not, these are like consent is taken and then MTP can be performed. Okay, cool. What about these two things? Here in the first image, axial section of abdomen is given, and now you have all of these bowel loops which are floating outside. What is this diagnosis? This is गैस्ट्रोस्काइसिस. टेल मी कि अगर मुझे ऐसा ही अपीयरेंस एक 10 वीक के फीटस में मिला, इज इट गैस्ट्रोस्काइसिस और इज इट नॉर्मल? When I ask you this, yeah, it is normal, right? Because does bowel come out for a trip during 9 to 12 weeks? Is there physiological herniation during 9 to 12 weeks? Yeah, so if it is seen between that time, it is physiological. But after 12 weeks, when you see that bowel loops are floating outside, they've still not returned where they had to, it is anomalous, it is gastroschisis. Yeah, so you will only see bowel loops. Is there any membrane? No membrane. And is it in the midline? No, it is towards the right of midline. On the other hand, when you see कि ऐसा membrane वाला well defined sac, rounded sac, what is this? This becomes omphalocele. Yeah, so this is omphalocele with a membrane in the midline. ये बिल्कुल ही apex, umbilical cord इसके apex पे attached होगा, right? Solid organs can also come out. Liver बहुत commonly निकलता है omphalocele में, and which has higher associated anomalies, it is omphalocele. Okay. Final thing ये भी नहीं पूछेंगे mostly. When you see in the thorax, so this is a coronal plane of the baby and this is the diaphragm. So diaphragm के ऊपर basically, I mean not diaphragm के ऊपर but within the thorax basically you have stomach also, you have heart also. So when you see stomach heart in the same plane, it is congenital diaphragmatic hernia. Alright, so slightly difficult, ये नहीं पूछेंगे mostly. And what is this? ये पूछ सकते हैं. Two babies which are fused at the chest. So this becomes what? Conjoined twins, thoracopagus, the most common variety which is thoracopagus, right? So chest is fused. Cool. So these are the anomaly scans. Just one more finding that I want to show you here. This is the abdomen and here you see black pani, right? So whenever there is fluid within the baby, ascites hai plus skin edema. What does this mean? This means hydrops. Okay, so the hydrops also can be detected antenatally. They not ask you this. But if you do not do anything about hydrops, then what will happen? Then this will happen. What is this? This you need to know for sure. Here you have the skull bones which are all overlapping. Can you see these white bones which are all overlapping here? That is the Spalding sign. And what does that indicate? That indicates a bad thing, which means that there is fetal demise, right? You have missed the fetal hydrop stage or whatever was the cause of fetal demise, and now there is fetal death. Various other signs, you have Roberts sign wherein heart के अंदर gas shadow आ जाएगा, usually in 12 hours. Spalding appears after 7 days. Ball sign wherein the spine will be hyperflexed. Helix sign, crowding of ribs. So these are the various signs. If they do ask you earliest sign obviously will be picking up fetal cardiac activity being absent, right? So this is the earliest thing that you can pick up. Fetal movements are not there, fetal cardiac activity is not there. That is the earliest sign. All of these signs are very late. Okay, so this is about fetal demise. Very quickly, let's do stroke in 5 minutes. So this is what they asked you in the last AIIMS exam. What? Anytime you have a focal neurological deficit patient, alright, so let me go back. If they give you a patient with non-reversible focal neurological deficit, they'll ask you, next step kya karoge? What will your answer be? It will be NCCT, right? So NCCT is what you will do. If NCCT shows me hyperdensity, if NCCT shows me hyperdensity, what does that mean? That means that there is hemorrhage. We are dealing with a hemorrhagic stroke. But if NCCT is normal or it shows me hypodense wedge-shaped area, what does that mean? That means that I am dealing with an ischemic stroke. What is going to be your next step? If I tell you कि ये मिला, अब क्या करोगे next? Now you have to start IV-TPA. How? What are the two things you will ensure before starting IV-TPA? One, are there any contraindications to IV-TPA? Second, is the patient within the window period? क्या patient window period में है या नहीं? ये दो चीजें करेंगे. Alright, but in the exam which was held last year, they did not give IV-TPA as the option, right? They asked you what is the next investigation you will do. Radiology wise investigation क्या करेंगे? Okay, so investigation wise next thing will be CT angio. Alright, so CT angiogram is the next imaging algorithms tell. So CT angio tells us if it is a large vessel stroke. Alright, it's a large vessel stroke. Alright, so that is what will CT angio tell us. And how it is important? This tells us कि क्या इसमें basically is there any potential for doing intra-arterial interventions or not. If the patient doesn't fit into the window period, then this becomes very very important. So usually क्या करते हैं in practice, you know why CT angio is important here. Just imagine yourself being interns. Go back to the time when you were interns. You have shifted one patient to CT room for NCCT. ठीक है, stroke का suspected patient है NCCT का. When there is an investigation which can be done in the same room at the same time, जो आपको बाद में ज़रूरत पड़ सकती है in a lot of cases, would you want to do it same time? या फिर patient को फिर से ED में लेके जाओ, give IVTP and rule out all everything, and then again you have to come back for CT angio. तो बताओ logistically what is feasible? कर लो CT angio, give contrast, you are in that same room, finish it off so that you know that these are the therapeutic options that this patient has, right? So basically that is how the examiner must have asked. Okay, so remember NCCT followed by CT angio. That was the basis of your question. Why not diffusion? What is the importance of diffusion weighted imaging? It is the most sensitive to pick up ischemia. मतलब ischemia के बाद earliest what can pick up a stroke? Diffusion weighted imaging. But is it relevant anymore? Once I've done NCCT, I know it's an ischemic stroke. I know where the thrombosis is. Is there any role of DWI now? No. DWI का role कब आता? अगर मेरा स्पेशलाइज्ड स्ट्रोक सेंटर है, आई हैव अ स्पेशलाइज्ड स्ट्रोक सेंटर, कैन आई डायरेक्टली टेक माय पेशेंट अप फॉर डिफ्यूजन वेटेड एमआरआई? Yes, then you can. You will know whether you have hemorrhagic stroke, you have ischemic stroke, straight away you take. But once you have started your journey with NCCT, then DWI doesn't have any role, right? Is this clear, everybody? समझ में आ गया? तो ये है. बाकी I've attached this table of contraindications. So do you remember where we were at in our journey? IVTP देना था, दो चीजें असेस करनी थी, contraindications है या नहीं, विंडो पीरियड है या नहीं, राइट? सो contraindications के लिए BP more than 185 by 110, bleeding diathesis, head injury या intracranial hemorrhage, surgery within 14 days, GI bleeding in 21 days, recent MI. ये है बुरी तरह रटो. ऑलराइट, सो वन ऑफ यू रिक्वेस्टिंग फॉर BTR, ये रट लो इसको. ऑलराइट, सो दिस इज समथिंग विच इज वेरी वेरी इंपॉर्टेंट. एंड इन योर एग्जाम दे गिव यू BP which was lower than 185 to 110. So it is not a indication of labetalol or it's not an indication or a contraindication basically. Window period कितना मानते हैं बताओ? 4.5 hours. Alright, so the patient who was, what is the operative term here? Last seen well, है ना? मतलब अगर रात को 10 बजे पेशेंट सो गया and सुबह he is having focal neurological deficit, is his window period 4.5 hours? You will say कि अभी अभी तो उठा है तो अभी अभी उसका विंडो पीरियड स्टार्ट करो. नो, ही वॉज लास्ट सीन एट 10 PM. मतलब हिज विंडो पीरियड विल बी 10 PM to 6 AM when he is woken up with a deficit, right? So already he is 6 plus 2, 8 hours into his period, right? So remember, last seen well is very very important for calculating window period. Apart from that, if CT scan shows a very very large area of ischemia, 1/3 के ऊपर, that again becomes a contraindication because there's very high risk of hemorrhagic transformation. Ischemic stroke can undergo hemorrhagic transformation because of reperfusion injury. Alright, तो अगर बहुत बड़ा stroke है, इसके लिए अपन aspect score grading होता है, वो भी यूज करते हैं. ठीक है, ओके, तो ये है. और रटना है तो ये एक और एग्जॉस्टिव लिस्ट है ऑफ ऑल दी कॉन्ट्राइंडिकेशंस जो मैंने आपको दी है इन द PDF. जस्ट गो थ्रू इट इफ यू वांट. ठीक है, ऑलराइट, कूल. सो एक बार फिर से, हाँ चलो बताओ. सो नाउ आई एम शोइंग यू इमेजेस बिकॉज आई एम अ रेडियोलॉजिस्ट. Non-reversible focal neurological deficit, and this is the appearance that you are seeing. Anybody can make the diagnosis of what kind of a stroke we are dealing with. If you look very carefully, hypodensity है यहाँ पे, wedge shaped hypodensity. Something else also, one other sign also we are seeing. Very good. This is the dense MCA sign, right? Wherein there is white thrombus within the MCA. This is telling us that okay, you have an MCA stroke that you are dealing with. Obviously, these are two different cases, but just to show you what are all the signs of ischemic stroke. Can the CT be normal in an ischemic stroke? Yeah. Early stages we might not pick up these signs, all right? So ischemic stroke can be normal also. So any normal scan, you assume it to be stroke clinically. Okay, next case. What is the diagnosis? When I show you this image, first of all image को identify करो. बता रही हूँ पेनम्ब्रा के बारे में very soon. This is diffusion, right? So anytime you don't see कि आसपास का skull नहीं दिख रहा, कुछ नहीं दिख रहा, it is diffusion weighted imaging, and these white areas represent diffusion restriction. Diffusion restriction कहाँ मिलेगा? Acute ischemic stroke. Brain abscess will have thick pus, diffusion restriction. Whereas with cyst, epidermoid cyst. That is how we distinguish arachnoid from epidermoid. Epidermoid has thick keratin, will cause diffusion restriction. Tumors, very cellular tumors will show diffusion restriction. So इन चार चीजों में diffusion restriction मिलेगा. Okay, so this is DWI showing us ischemic stroke. And what is this investigation? जब color अचानक से black and white की दुनिया में color आया, this is CT perfusion. So अगर पूछे पेनम्ब्रा देखने के लिए क्या करोगे, इसकी डिटेल्स तो नहीं पूछेंगे, but if they ask you what will you do to see penumbra, you'll say CT perfusion. Okay, are all of these modalities clear? Two more images very quickly. On a non-contrast CT, when you see a triangular hyperdensity here, what is this? This is a superior sagittal sinus thrombosis. It can appear as a filling defect. अगर CECT है उसको अपन बोलते हैं empty delta sign. अगर white दिख रहा है on NCCT, it is indicative of thrombus, which is called the cord sign. Okay, so this is superior sagittal sinus thrombosis. हमेशा arrow लगा होगा. They will not ask you SSS thrombosis without marking for you. ऐसे ही यहाँ पे arrow लगा है when it's a small ischemia, small volume ischemia. What is this? This is a lacunar stroke. All right, so small volume usually seen in the putamen. Lacunar stroke because of lipohyalinosis, atherosclerotic narrowing of the lenticulostriate branches. Okay, that is what is used. Right, so that is what you need to know. Okay, renal masses, again something that they love to ask. So let's do this topic very quickly and we'll stop after this. 37-year-old banker presents to the whatever with flank pain and a renal lesion is detected on CT. What is the likely diagnosis? I will take next 10 images, bus. Day after tomorrow we will start everything about FMG. Alright, now there are no other exams on my mind except FMG. So next 10 days of November, that is all we are going to do. Okay? Okay, wonderful. Angiomyolipoma. ठीक है, fine. I am so glad that we did this class because again, banker सुनते ही अपना दिल बोलता है angiomyolipoma, and universally everybody is saying angiomyolipoma and everybody has thrown their oaths out of the window except Praveen. Very good, Praveen. So why are you saying RCC? Why are you going against all your colleagues who are saying angiomyolipoma? Because there is no fact. Guys, oath, like so many times I have taken this oath with you कि I will look for this black color. Do you see this black? एक कोने में skin है, उसके नीचे fat है. ऐसा black color somebody identify for me in this lesion. कोई दिखा दो कि इस lesion में fat है. ऐसा color का काला काला कुछ है. दिख रहा है किसी को? नहीं दिख रहा ना. यहाँ पे भी देख लो fat का color. You want to see more fat color? See here. All of this is mesenteric fat. Is there fat in this lesion? No. This is a heterogeneously enhancing lesion. This is just grey, guys. This is grey. ये grey color यहाँ देखो पानी का grey है. This is necrosis. So this is not angiomyolipoma just because he's a banker. Please, guys, bankers are not destined to have angiomyolipomas. Just leave them alone. They can have RCC. If a banker comes to you and says, I have a renal mass, you will start treatment. Go for embolization. You have angiomyolipoma. No, you will scan him and you will make a diagnosis based on image. Okay, so this is renal cell carcinoma. This is a heterogeneous lesion which is showing necrosis. Okay, so this is RCC. अब ये diagnosis बताओ please. Now tell me what is the diagnosis of this lesion. Again happens to be a banker. So two bankers come to you with two different lesions. Now what does this person have? अब देखो color. Now it is black, this hypodensity, this negative Hounsfield unit. Yes, this is angiomyolipoma. This is how fat appears. This gray density is the myo component. You will rule out tuberous sclerosis in this patient, right? So remember how to diagnose AML. Again, they will be very typically bilateral multiple lesions. ये बता दो क्या है सेंट्रल स्कार. दिस एवरीबडी नोज. व्हेन देयर इज अ सेंट्रल स्टिलेट स्कार इट बिकम्स ऑन्कोसाइटोमा. क्या रूल आउट करोगे ऑन्कोसाइटोमा में? इफ आई से दिस पर्सन डेवलप्स pneumothorax, this person also has these follicular based lesions, you will rule out Burt Hogg Dube syndrome, right? So folliculin gene mutation, Burt Hogg Dube syndrome, ऑन्कोसाइटोमा. ठीक है, कल लिस्ट बनवाया था सेंट्रल स्टीलेट स्कार वाला. ओके, ये बताओ अब ग्रे लीजन लेफ्ट किडनी में, just like pani of gallbladder, just like pani of spinal canal, this is a pani filled lesion, this is a water filled lesion which is a cyst, right? This is a renal cyst. क्या बोलोगी इस पर्सन को? कितना परसेंट रिस्क ऑफ मैलिग्नेंसी ही हैज? What, on the basis of which classification will you say that he has this percent risk of malignancy? Based on Bosniak, right? So Bosniak classification tells us about risk of malignancy in cyst. So what about this man here? इसको क्या है? Yes, very good. इसको बोलो कि तुम चिल मारो, you are Bosniak 1. You are a very very good simple cyst जिसमें कुछ नहीं है, no septations, nothing, right? So this is a Bosniak 1 cyst, 0% risk of malignancy. तो कैसे बताएंगे Bosniak? 1 is simple cyst, खाली पानी, 0. 2 में क्या होगा? thin cyst. Why not RCC? It's filled with water. RCC will not be filled with water. RCC will be very solid, very heterogeneous, very white. It is a vascular tumor, right? So it will be white with areas of necrosis. Got it? Okay, coming back. When you have thin septations, that is Bosniak 2. Again, no risk of malignancy. बट अगर नोड्यूलर कैल्सिफिकेशन है ना, नोड्यूलर कैल्सिफिकेशन मिल गया वॉल का, सेप्टे का, थिक कैल्सिफिकेशन, या फिर मल्टीपल सेप्टा मिल गया, देन यू हैव अ 10 to 12%. 2F, F फॉर फॉलो अप, कि फॉलो कर लो इसको यार, रिस्क मत लो, 10% रिस्क है. ऑलराइट, बाकी जाता है 3 and 4. 3 and 4 are malignant unless proven otherwise. I mean, they are taken as malignancy, they are both rejected. 3 is 50 to 60, this is 100. इसके लिए क्या चाहिए? Any enhancement. The trick is पूरा याद मत रखो, any enhancement becomes 3 और 4. अगर septa thick enhancing है 3, अगर solid nodule है which is enhancing 4. ठीक है, तो simple है. 1 and 2 do nothing. 2F nodular calcification, follow it up. 3 and 4 any enhancement of septa, any enhancing nodule, you resect it, right? So that is Bosniak classification. ओके, गॉट इट. सो ये देखो, अब इसको क्या Bosniak दोगे? सबको दिख रहा है यहाँ पे एक सिस्ट है किडनी में, और उसके अंदर क्या है? सेप्टेशंस है. कैसे सेप्टेशंस है? मल्टीपल थिकन्ड सेप्टेशंस, राइट? सो दे आर ऑल थिक सेप्टेशंस दैट आई एम सीइंग हियर. सो क्या Bosniak देना चाहोगे इसको? Yes, RCC is Bosniak 4, or the better way to put it, Akshay, would be Bosniak 4 is RCC unless proven otherwise. It is RCC to solid mass, right? Bosniak is only useful for cyst. Does that make sense? मतलब अगर Bosniak 4 category cyst है, cyst with solid nodule, that is RCC unless proven otherwise. Yeah. हाँ, अच्छा, 3, very good. So there are thick enhancing septae, it becomes Bosniak 3. I agree with all of you. We have to resect it. Okay, understood? ये बता दो, भरपूर cyst, multiple, innumerable cyst with outer margin, adult patient who's come to you, MRI showing white cyst, ultrasound showing black cyst. So does that also tell us about intensity of water? T2 weighted image, water is going to be white. Water on ultrasound always anechoic. Kidney is replaced by multiple cysts. IVP shows us this spider leg appearance. ऐसे करके बेचारा pelvic alluvial system is going. Correct? Autosomal dominant polycystic kidney disease. Age of presentation, adult. Large cyst. The kidney is entirely replaced. Outer surface irregular because of the cyst. Okay? This is about ADPCKD. On the other hand, a neonate who presents to you with a smooth outer contour, tiny cyst, bilateral, tiny cysts which are not even very well defined. What? that will be the diagnosis. When it's a bilateral involvement, it becomes autosomal recessive polycystic kidney disease. बट अगर मैं बोलूँ एक नियोनेट ही है जो बड़े बड़े सिस्ट लेके एक किडनी में आ रहा है, द एंटायर किडनी इज रिप्लेस्ड बाय दीज नॉन कम्युनिकेटिंग सिस्ट विच इज यूनिलैटरल. बायलैटरल कभी भी नहीं मिलेगा, इनकम्पैटिबल विथ सर्वाइवल. व्हाट इज दिस? दिस इज मल्टीसिस्टिक रीनल डिस्प्लेजिया और किडनी डिस्प्लेजिया और मल्टीसिस्टिक डिस्प्लास्टिक किडनी. यस, सो नियोनेट सुनते ही ARPCKD मत मारना. सी इफ इट इज यूनिलैटरल multicystic dysplastic kidney. Okay, one last image from kidney. What do we have? This is the flower bouquet appearance or a paintbrush appearance, right? And when I see the CT, what do you see white on CT? Calcification. I'm seeing calcification of the medullary pyramids on both the kidneys, right? Very good. So this is medullary sponge kidney, which is also having what? इसको क्या बोलेंगे जब calcification है medullary pyramids का? इसको बोलते हैं medullary nephrocalcinosis. Okay, so remember nephrocalcinosis is gonna appear white on CT. So pyramids का calcification है medullary nephrocalcinosis. अगर इधर cortex का calcification है cortical nephrocalcinosis, which is more common, medullary nephrocalcinosis, right? एक एम्स पर्टिकुलर क्वेश्चन जो आ सकता है बिकॉज दे लव टू आस्क अस. रिमेंबर हाइपर ऑक्सिल्यूरिया करके एक डिजीज है जिसमें मेड्यूलरी नेफ्रोकैल्सिनोसिस मिलता है. अपार्ट फ्रॉम दैट एनी कॉज ऑफ हाइपर कैल्सीमिया, मेड्यूलरी नेफ्रोकैल्सिनोसिस. मेड्यूलरी स्पॉन्ज किडनी, मेड्यूलरी नेफ्रोकैल्सिनोसिस. ठीक है, हाँ. सो दिस इज अबाउट दैट. हेड ट्रॉमा नहीं करा रही, यू गाइज नो हेड ट्रॉमा ना, इतना बता दो. ये सारे आंसर सही दे दिए तो बस मैं मान लूंगी दैट यू नो. इनिशियल इन्वेस्टिगेशन फॉर हेड ट्रॉमा, X-ray, ultrasound, CT, MRI, NCCT. Very good. Investigation of choice, best NCCT, MRI, ultrasound, X-ray. बेस्ट भी NCCT है. The ball stops at NCCT. जैसे गॉलस्टोन में अल्ट्रासाउंड सब कुछ था, NCCT सब कुछ फॉर हेड ट्रॉमा. One indication of MR, you just tell me one thing जहाँ MR का यूज आएगा. Only one, which NCCT can be normal. Poor GCS score, NCCT is normal. हम हमेशा पूछा जाया हुआ सवाल. Diffuse axonal injury, right? So diffuse axonal injury बोला, MRI. Best will be susceptibility weighted imaging. काले काले dots मिलेंगे. CT angio का indication ये नहीं बताओगे तो भी चलेगा. If you see subarachnoid hemorrhage, do CT angio to rule out aneurysm in cases of trauma also. And if you see vertebral foramen में जो foramen transversarium होते हैं उनका fracture. Alright, तो कोई भी vascular injury suspected है, do CT angio. Okay, alright, so बस इतने कर लो. बाकी न्यू ऑर्लियंस क्राइटेरिया कैनेडियन हेड CT रूल होता है फॉर इंडिकेशंस, लॉजिकली हो जाएगा. सो GCS लेस देन 13 यू हैव टू डू इन एवरीबडी. 13 to 15 यू डू ओनली इफ डेंजर साइन, फ्रैक्चर सस्पेक्टेड है, 2 वॉमिटिंग. इसमें हमेशा ऑप्शन आता है 1 एपिसोड ऑफ वॉमिटिंग. ओके, सो रिमेंबर एक वॉमिटिंग तो सब करते हैं, यू नीड 2. ऑलराइट, सो दिस इज हाउ यू नीड टू रिमेंबर. Elderly, you do amnesia, lucid interval, dangerous mechanism. Okay, so हमेशा ऑप्शन में आएगा 1 एपिसोड ऑफ वॉमिटिंग, नहीं करना उनका CT. ओके, राइट. ये बता दो, एम्स के रिपीट क्वेश्चन करा देती हूँ, पूरा ही हो जाएगा. 2-year-old child with history of fall 1 year back, 1 साल पहले गिरा और अब आ रहा है, which now painful and growing parietal swelling. Last year he had a parietal bone fracture and now he is having a swelling which is growing. What is the diagnosis? गुड, नाम में पता लग रहा है स्कल फ्रैक्चर जो ग्रो कर रहा है. वेरी इजी, ग्रोइंग स्कल फ्रैक्चर. इट्स ऑल्सो कॉल्ड व्हाट? लेप्टोमेनिंजियल सिस्ट. ऑलराइट, सो ये बच्चों में मिलता है. 3 क्राइटेरिया हैव टू बी फुलफिल्ड फॉर ग्रोइंग स्कल फ्रैक्चर. बच्चों में होना चाहिए, इट्स अ डिलेड कॉम्प्लिकेशन, usually after 3 months. 3 months to 1 year is the usual duration, and there is fracture plus dural tear. Dural tear. So dural tear हुआ मतलब dura भी फटे, so साथ में the fluid, the CSF is also herniating as a cyst, and that is not letting the fracture heal. Okay, so this is growing skull fracture, this is leptomeningeal cyst. Is that making sense to all of you? So this is very very important. EDH, SDH, you guys know. This is subarachnoid hemorrhage, जब white areas मिलेंगे अपने को. EDH, SDH you know ना, please don't get it wrong. EDH बता ही देती हूँ. EDH here you have idly shaped biconvex lenticular, it doesn't cross the sutures, it can cross the midline. SDH It can cross the sutures, it doesn't cross the midline. Trivial trauma, venous injury, banana shaped. Okay, चलो ये बता दो क्या है. When you see blood, white acute blood here, it becomes intraventricular hemorrhage. Within the lateral ventricles you are having white blood, and these gray areas are the clots. This is intraventricular hemorrhage. जब white areas cerebrum में आ रहे हैं, what is this? Favored areas, frontal and temporal bones, because a lot of bony projections are here. This is cerebral contusion. I have seen kids who will confuse this with concussion. यहीं पे लिखा हुआ है. So concussion is where you have CT which is normal. Remember, concussion is just कुछ नहीं मिल रहा. तो ऐसे मूवीज के लिए है कि इसको कॉन्कशन हुआ है. somebody will pretend ना कि मुझे I don't know who you are, and if you do CT and MR everything is normal. So when there is no organic counterpart of the injury, it is cerebral concussion. Alright, ऐसे बोल देते हैं concussion हुआ. Right. Young male with head trauma brought to ED in unconscious state. ये नाटक नहीं है. This is not like concussion. Unconscious, intubated with low GCS score, and yet the NCCT comes out to be normal. What is the likely diagnosis? When GCS is poor, then you have to rule out correct diffuse axonal injury. Alright, so this is what they'll ask, and what will you do next पूछा तो हम करेंगे MRI. ठीक है, एक और सवाल लास्ट एम्स का. You guys remember very well. Black dots. So this is what is susceptibility weighted imaging. These are your hemorrhagic foci, diffuse axonal injury. This is how it appears. So CT can show you tiny particle hemorrhages, or it can be normal also. Ek word for you and you will tell me diagnosis. Pulsatile proptosis following trauma. बस इतना सा बताऊंगी. CT angio किया, something like hockey stick. Superior ophthalmic vein is very dilated. What is the diagnosis? Wonderful. Karyotico cavernous fistula. There's an injury to internal carotid artery, and that's communicating with the cavernous sinus, right? So this is Karyotico cavernous fistula. Gold standard investigation of choice. Something you have to do is DSA. DSA में अपने को मिलेगा communication between the ICA and the cavernous sinus. Okay, so that is where you block it. Okay, that is treatment. Head trauma भी कर लिया. Wonderful. Fast 5 MCQs. Are you guys ready? Very quickly 5 repeat question देख ले. All of the following are useful in osteoporosis. DEXA. चलो आप आंसर करो तब तक. हाँ मैं बताती हूँ साथ साथ. DEXA, yes, it's the best investigation. Dual energy X-ray absorptiometry. Quantitative CT, yes, this is a recent advance. This definitely has a role in osteoporosis. Bone scan has no role. Bone scan only has a role wherever there is new bone formation. मतलब only in tumors, osteomyelitis, bony metastasis it has a role. No role in osteoporosis. Chemical analysis always. Do you remember the table we have filled so many times? Calcium phosphate, ALP, PTH. All of these will be normal in osteoporosis, but they have to be analyzed, right? So 1, 2 and 4. That is the correct answer. Okay, cool. Patient presents with fever and cough with expectoration. Chest X-ray shown. What is the likely causative organism? क्या है ये? Air का गोला. What is this called? When you see it with fever, cough with a pneumonia case, this means it is a pneumatocele. Pneumatocele is associated with which organism? Staph. Alright, so remember Staph aureus. 2 words you have to remember. एक pneumatocele मिलेगा. Second हिस्ट्री में दिया होगा पोस्ट वायरल URTI. न्यूमोनिया हुआ है ना, कि बहुत टाइम से होता है ना ऐसा. अपने में भी बहुत टाइम से URTI ठीक ही नहीं हो रहा. अब कफ विद स्पूटम आ गया, मीन्स LRTI बन गया. सो द लाइकली कॉजेटिव ऑर्गेनिज्म इज स्टैफ ऑरियस. ओके, ये तो बता दो, ये तो पढ़ लिया है. तो टेस्ट फॉर ऑल ऑफ यू. ब्लंट ट्रॉमा, ई फास्ट. रिजल्ट को इंटरप्रेट करो. इक्विवोकल कैन नॉट कमेंट, कभी आंसर नहीं होंगे. सो 2 आर रूल्ड आउट. 50-50 फॉर यू. What is this? This is liver, this is kidney. Is it fast positive? Do I see something kala? Yup, I do. So anytime you see black colored fluid separating liver, kidney anywhere in the fast, it is a fast positive scan. If the patient is stable, what will you do next in this particular case? You will go ahead and do CCT to find the definitive cause, right? So stable patient, CCT. Unstable patient, explore if fast is positive. ओके, आज का ही टेस्ट. नियोनेट presents with a palpable mass in left lumbar region. Ultrasound is shown below. Tell me the diagnosis. Wilms tumor, neuroblastoma, ARPCKD, multicystic dysplastic kidney, E, autosomal dominant polycystic kidney disease. Very good, very smart. Multicystic dysplastic kidney. एक तो unilateral, second तो neonate, third large cyst. ARPCKD will be bilateral. Apart from that, will I see large cyst? No, I will see very very tiny cyst. ADPCKD ऐसे cyst तो मिलेंगे but bilateral, adult. Alright. Wilms tumor, neuroblastoma, solid tumors, not cystic diseases. Okay. Everybody, is this making sense? टिग्रॉइड पैटर्न ऑन एमआर, बड़ा ही क्लीशेड सा सवाल, इसमें बस टाइगर और टिग्रॉइड को कंफ्यूज मत करना. इफ टिग्रॉइड पैटर्न इज आस्क्ड, पेजिलियस मर्सबेकर and metachromatic leukodystrophy are two things you have to remember. If they ask you pantothenate kinase, what is the sign here? It is eye of the tiger. Globus pallidus में eye of the tiger मिलेगा. So it is not tigroid, it's eye of the tiger. Okay? So ये देखो, इनमें से बताओ कौन सा tigroid है. Can you see how tiger जैसा ऐसा white matter में venules pairing है? It's because of veins paired in leukodystrophy. Okay, so this is the tigroid pattern seen typically with metachromatic leukodystrophy. What is the enzyme deficient? Aryl sulfatase, right? So do you remember aryl now? कुछ it is metachromatic leukodystrophy. When you have in globus pallidus, tiger की आँख जैसा, it is eye of the tiger. Okay. इसमें एमआर का सीक्वेंस पूरा उल्टा दिखता है ना. हाँ, मतलब हाँ, एज इन वाइट मैटर अपीयर्स वाइट, ऑलराइट, बिकॉज दैट इज इडीमेटस ना, वो अबनॉर्मल है. पैथोलॉजी हमेशा T2 में हाइपर इंटेंस दिखेगा, इसमें वाइट मैटर अपीयर्स हाइपर इंटेंस. ओके. हाँ, आई ऑफ द टाइगर साइन सीन विद पैंटोथेनेट काइनेज न्यूरोडिजेनरेशन. इसको NBIA भी बोलते हैं, न्यूरोडिजेनरेटिव डिजीजेस विद ब्रेन आयरन अक्यूमुलेशन. इसका पुराना नाम था हेलेवॉर्डन स्पॉट्स. ठीक है, तो ये सब कुछ ही है. बस डन. ऑलराइट, सो दिस वी हैव completed everything. Today we did 7 topics. We did 7 topics today, which is great. So all the best everyone. I'll see you all one more time, one last time, 7 o'clock for radiology final images. If radiology is still not done, we'll just finish off all the images at 7 p.m. today. 30 more minutes, and then tomorrow 4 o'clock for final 30-minute advice on how to give the exam. Okay, so thank you so much guys for sitting for 4 continuous hours on 4 days and learning some radiology also from me. And annotated PDF, yes, this only I can post, alright, because Purane I did not save. I will post this. Okay, bye.